my name is Dr. Sanjay Juneja, also known as the Onc Doc on TikTok and Instagram. And today we're going to talk about chronic lymphocytic leukemia, or SLL or CLL. Basically, this is a problem with your lymphocytes, which is part of your immune system. If you look at your CBC, your complete blood count, and your differential, you'll always see lymphocytes there. This is a problem when you have a clone that's all the same. And that's like any cancer. So if you watch my previous videos, cancers are when a normal cell that does what it's supposed to all the time, all of a sudden starts cloning itself. That's when something is abnormal. So CLL or SLL actually has a kind of pre-cancer or pre-chronic lymphocytic leukemia status, and that's called monoclonal B lymphocytosis. And that's just a big fancy term to say, yeah, there's a bunch of these clones, but there's not enough to call it CLL. And how many is enough? 5,000. So once you have consistently 5,000 or above over 3 months on your differential, that's when you do something called a flow cytometry to look at the receptors and basically how that lymphocyte looks and see if there's a big clone of them. And if there's over 5,000 that are all the same clone, then now you're considered to have CLL or SLL. If there's less than 5,000 but there is a clone, it's monoclonal B lymphocytosis. Now in the whole spectrum of cancers, this is a blood cancer. It's not a solid tumor cancer like lung or pancreas, but it's one that's really quite forgiving in the sense of the symptoms that you have and how long you can live with it. It's one of the few cancers that you can actually just watch. CLL is generally not thought of as genetic, though some studies you look and you see that some family members, first degree, usually will have that monoclonal B lymphocytosis, which does not necessarily mean you ever turn into CLL. There are patients that will have CLL with lymphocytes all the way up to 75,000, 100, 150,000, believe it or not, without any problems or not needing treatment. The reason is because the lymphocytes are actually pretty small. So if you have acute leukemia or even chronic myeloid leukemia, which is CML, myeloid instead of lymphocytic, which are the lymphocytes, those cells, the myeloid cells, are bigger, especially blasts. So they're big and they can cause kind of sludging, which makes you have symptoms sooner at much smaller counts. Also, if you get a peripheral smear, which is a staining of the blood on a slide, you'll see what are called smudge cells. And basically, it's just that lymphocyte, because they're frail, it's just like kind of flat and popped on the cell. And if you have a bunch of smudge cells on differential, where you have high lymphocytes persistently, you think of CLL. So it is staged. It has stages actually 0 through 4, but it's not the same kind of staging when you think about a solid tumor cancer. Stage 0 means it's just in the blood. So you have CLL, but it's just circulatory or in the blood system when you get a blood sample or a CBC. That's stage 0. Stage 1 is when you have it in the blood as well as lymph node involvement. So a lot of times it'll be in the neck, it'll be bulky and you know, it progressively gets bigger and it doesn't go away, or it can be in the axilla, or sometimes in the groin. Stage 2 is if you have the lymphocytosis in your blood. That's for all stages, obviously, because that's how you diagnose it, as well as having a large liver or spleen that is thought to be from the CLL, called hepatosplenomegaly. And then stage 3 is when it's enough in your body, and specifically possibly your bone marrow, that causes your blood level to be below 10, your hemoglobin. So you're anemic below 10, but every other reason for your anemia is eliminated, meaning people have anemia or a hemoglobin of 9 and don't necessarily have CLL. So you need to make sure it's nothing else. That's stage 3. And then stage 4 is if actually your platelets are below 100,000. Now, like I said, if it is not causing cytopenias or your blood or platelets to be low, like I mentioned, then you can actually just watch it. If you don't have weight loss that's persistent and unintentional, profound fatigue that you're not used to, if you don't have big bulky lymph nodes over 10 centimeters or have a bunch of stations over 5 centimeters, like in multiple places, and if it's not painful and you're not having fevers, if basically you didn't know better unless they checked it on your blood, or even if you saw the lymph nodes but they weren't bothering you, there's no decreased benefit or worse survival to just watch it and wait to treat until you need it to. And by until you need it to, I mean those things that I just mentioned, or the cytopenias. How do you treat it? There's a whole bunch of drugs that have come out now, but by far, across the board, the most popular way to treat it is with something called ibrutinib. It's an oral pill that you take, and it can actually control it for up to years. The biggest side effects are atrial fibrillation and increased bleeding and bruising. And sometimes if you're high risk for those, you may do its kind of cousin called acalabrutinib. These are both oral pills. The problem is it requires therapy forever. There are two therapies where when you get it, you're done. Okay, one, the original one, which you've been using for several years, is called FCR. That is chemotherapy, and that's going to be fludarabine, cyclophosphamide, and Rituxan, which is like a CD20. It's an antibody, but that's FCR. And you use that because it's finite, and then you're done with your therapy and hope you're in a really long remission, like years. The thing is, this is only reserved after all the data has been collected and where we are today with all of our good options for people that are under 65, super fit, and super fit meaning that, they can actually do sports and stuff, and they have something called IgH mutation, or they're IgH mutated. That triad is where you want to think about FCR. Otherwise, if you're not IgH mutated, you probably don't want to use FCR anymore. Why? Because there is one additional therapy option that lets you have a finite amount of time that you need to be on therapy. And that's the combination of venetoclax and obinutuzumab. Obinutuzumab is like Rituxan, it's an anti-CD20 antibody, and venetoclax is an oral pill. And you take this for a year, and again, you can have a really long sustained remission for years, and the side effect profile is pretty good. It's not that intense chemotherapy or general, cytotoxic or poison chemotherapy like we see in FCR. Outside of 11 and DEL17 and TP53, everything else is neutral or normal, except for 13q. 13q deletion is actually really good. You want to have a 13q deletion because that is the best prognosis of all of them. I hope this was helpful on you understanding CLL and SLL. It's not uncommon at all in the American population as well as across the world. If you have any questions, please drop a comment below, share this video, subscribe. The more users that participate, the more it'll really incentivize us to teach all the things that we want to learn about cancer so we can understand it well and not have our disease own us, but us own our disease with understanding.